ICL-related cataracts are extremely rare with the newer versions of the ICL. Whether they had LASIK or an ICL before, patients will again ask for refractive solutions at the time of cataract surgery. Thanks to an unaltered cornea, we can fully rely on biometry and topography data in this ICL case. A cohesive OVD is used to create space in the AC and to protect the cornea. We like to lift the ICL into the AC with the OVD cannula. In order to prepare for ICL removal, 2 or 3 haptics are placed in front of the iris. The best place to grab the ICL is the edge of the optic zone because of its thickness. We prefer an oblique axis as this will allow to extract the ICL with the smallest possible corneal incision. But in this case I exaggerated a bit in terms of small incision removal and I had a couple of unsuccessful bites into the ICL. In the end, I had to enlarge my 2.1 incision to 2.4, mainly on the inner lips of the incision. Which of course is still not bad given the fact that we were dealing here with the largest ICL size of 13.7 mm. The ICL is very thin and floppy and will always allow for safe removal as long as you use enough OVD. On a side note, I take the opportunity to highlight the challenge of capsular rhexis sizing in large myopic eyes. First of all, the rhexis will always look smaller because we cannot rely on the pupil size of these oversized eyes. And second, the lens has a lot of space to move around in these large eyes and potentially to subluxate. You therefore want the rhexis to really overlap the optic a full 360 degrees, stabilizing the lens in the long run. So in large myopic eyes, always aim for smaller and you will do well.